Welcome, everyone, to TMA's Myositis Research Insight. My name is Dave Mokel, and I'm the immediate past chair of TMA's Board of Directors. This webinar series is designed to connect patients and their families to specific myositis researchers in our community. Before we get started, please note that this webinar is being recorded and will be available on TMA's YouTube channel next month. We would love to find out where you are all joining us from, so please put your state or country in the chat. And please put any questions, different than the chat, please put any questions for Dr. Johnson today in the Q&A box at the bottom of your screen. We are pleased to discuss the research of Dr. Cheilonda Johnson, who is a pulmonologist and expert in autoimmune-related interstitial lung disease, or ILD, at the University of Pennsylvania and member of TMA's Medical Advisory Board. Dr. Johnson's groundbreaking research focuses on understanding the clinical and genetic factors behind autoimmune ILD, or interstitial lung disease, which is a serious condition often associated with myositis. In this webinar, Dr. Johnson will share insights from her recent pilot project funded by TMA, which identified genetic markers linked to ILD in myositis patients. This work, which includes unique lung tissue sampling database, reveals critical information on how myositis genes can predict not only who's at risk for ILD, but also the severity of the disease. Dr. Johnson will discuss these and other findings of her research and what they mean for advancing treatments and improving outcomes for myositis patients. Welcome, Dr. Johnson. Thank you for being here, and thank you for, most of all, taking time out of your busy day to be here with us.
Thank you so much. It's my pleasure to be here. I'm just going to share my slides with you all. And so, as the kind introduction suggested, my research covers a breadth of topics. I thought that I would spend today, though, focused on one particular area of interest, which is the primary focus of what I'm doing currently, and was made possible only because of the funding that I received from the Myositis Association. And so just a little bit of background. One of the questions that I think comes up often is, what is interstitial lung disease? And so I figured that I would start with some basics just so that we're all on the same page. And so, as you know, myositis is an inflammatory disorder. It affects multiple organs in the body, including the lungs. The lungs can be affected in a variety of ways, but the most common and consequential way that myositis affects the lungs is through interstitial lung disease, or ILD. And the interstitium is a difficult thing to explain. Essentially, we have this network of fluid and tissue-filled spaces throughout our body that's in between organs and cells. And in the lungs, there's interstitium between the air sacs of the lungs, or the alveoli, and the blood vessels in the lungs. And unfortunately, with certain disorders, including autoimmune disorders like myositis, you can get inflammation or scarring in this space. And the result of that is that you have difficulty expanding the lungs, and so people will become short of breath, particularly with exercise. And if there's enough inflammation or scarring in that space, you can have difficulty exchanging gases, and primarily of which in patients with ILD, the issue is with transferring oxygen. And so for some patients, they'll have actually an oxygen requirement. And the day-to-day life of patients with interstitial lung disease can vary significantly. Some people are completely asymptomatic. Some people are quite functionally compromised. The most common symptoms are shortness of breath when you exert yourself, cough that's dry, meaning you don't cough up phlegm, and as I mentioned, some people, the need for supplemental oxygen. And so what inspired me, and so a little background that some of you may not know, is that when I was trained to be a lung doctor, I worked at the Myositis Center, and so I had exposure to patients with myositis and ILD. And at that time in my mind, I was pretty fascinated by the disease, but more importantly, I was very touched by the stories of the patients that I interacted with. And one of the things that I saw happening repeatedly was significant confusion around the disease, a lot of delays in diagnosis, and people presenting to us with quite advanced findings, at which point treatment was still possible, but there was a lot of damage that had already been done. And in my mind at the time, I thought that the most important thing that I could do was to be an advocate for patients with myositis ILD and to really do a good job of educating other pulmonologists and other people who care for patients with myositis about the importance of recognizing and treating lung involvement early. And there's been a lot of advocacy and awareness around myositis. Certainly, we still have room to go. And although I think that this is still an important issue and one that deserves attention, as I spent more time taking care of patients with myositis ILD, I realized that even if every single patient was diagnosed appropriately very early on and referred for appropriate treatment, there were still a lot of unanswered questions. And this is what really made me want to think about doing research in patients with myositis, because I saw that even when we knew exactly what the diagnosis was, there was still a lot of unpredictability within patients and between patients in terms of who was going to respond to treatment, what was the best choice of treatment, how long should people be on treatment, why do some people have such severe lung disease, other people have very mild disease. And so there was a ton of questions to answer besides just increasing awareness. And so this is why I devote my career to understanding this disorder. And so before I talk specifically a little bit about my research, I just wanted to highlight the process of translational research. And essentially, this is the process by which we go from having an idea to actually having a treatment that we can give to patients. And for patients, I know that this can be a really frustrating, lengthy process, and it feels like progress is slow. And oftentimes it can be, and that's because this is iterative and it requires a lot of collaboration. And unfortunately, it's also very expensive. And so you're starting from the point of scientific discovery, which we usually call basic science research. And this is when you do research in cells outside the human body or in what we call preclinical models, which are usually animal models, so things like mice or non-human primates. And then you get to the point where you actually develop a product that you want to see, is this safe to give to humans? And at which dose should we be giving it to humans? And so those are our phase 1 studies. And then eventually you can get to studies that look to see, is this drug actually effective? And so those are our clinical trials. And a lot of times people want to get right to the clinical trial, and I understand that. But there's a whole lot that goes outside of this realm. And even once we have clinical trials, there's still important work to do after that to make sure that the things that we find that are effective for patients are reaching all of the people who are potentially eligible. And that it's not just getting to certain patient populations, but to everyone around the world who would benefit from it. And so while I do work in some clinical trials, my research actually is outside of this kind of process. And what I focus on is primarily observational research. And so observational research is just as important as all the things I mentioned on the previous slide, because this is really where we look directly at patient populations and say, what are the areas where we actually need interventions, all those unanswered questions from the OWL. What is it like in the real world when we're giving people drugs not under the idealized settings of a clinical trial? And this is really where we start to kind of generate ideas for things that could potentially be targets for therapies. And so this is an important part of the translational research process, but sometimes it feels a little bit abstract to patients. And so this is why I wanted to explain it. But again, this is an important part of the research process, but doesn't directly lead to treatment, but over time, indirectly is very important in helping us develop treatments for our patients. And so these are some of the areas where just from observing patients, we've noticed difference in outcomes. However, as I was alluding to earlier, even when I have two patients who are identical with regard to all of these factors, there still can be a lot of differences in how these people behave over time, with regard to how quickly they respond to treatment, if they respond at all, if they progress or not. And so there's still a lot of unanswered questions. And so this next slide is a graphic of a slide that's often presented in patients with IPF that I modified for it to be more applicable to patients who have myositis ILD. And what you can see is that there's a lot of variability in how patients with myositis ILD will behave over time. And so we certainly are fortunate in that, unlike patients who have conditions like idiopathic pulmonary fibrosis, patients with myositis ILD can get better, or even if they have some loss of lung function, can eventually stabilize and go into clinical remission. Unfortunately, we still do have patients, however, who have progression. Some of those patients progress rapidly. Some of those patients progress more slowly. And then there's another group of patients who may have periods of stability that are then interrupted by periods of exacerbations in a setting of things like infection or disease flares, where they then drop down to a lower level of lung function, stabilize again, and then potentially have future insults. And part of the challenge for me is that whenever I see a patient at the time of diagnosis, I don't currently have great tools for me to be able to predict which one of these pathways any individual patient will go down, which is incredibly frustrating for the patient, because they're looking for some guidance in terms of what to expect. And this is only a pattern that becomes apparent after some time has passed, sometimes a number of years. And so one of my current focuses is to try to come up with better ways of predicting who will fall into each of these categories. One, so that we can recognize and treat those people who are at higher risk of having bad outcomes early and aggressively, but also so that patients who may do better, we don't have to treat as aggressively, and we can offer them some reassurance. And so, as was mentioned before, I've been a recipient of a TMA pilot grant, which allowed me to have funding to do my research. And this research was really critical because at the time I had just recently transitioned my career over to Penn. We see a decent number of patients with myositis here at Penn. And there have been others who are doing research, including Dr. Worth, who's a dermatologist here. But we didn't have a good representation of patients with myositis ILD. And so the funding really went towards trying to understand more of the genetic risk factors for myositis ILD that I had worked on as a more junior faculty member, but also to be able to build a registry here to continue to do more research. And so fortunately, I was able to do that. And having access to that data was quite insightful, and it allowed me to build and answer some additional questions, including the ones I'm going to highlight today. And so far, about 200 people have enrolled in the registry, which is fantastic for a relatively rare disorder like myositis. The goal was to have half of the patients have ILD and half have myositis without ILD, but you can see that we're actually more like 60-40. And that's probably because I'm a pulmonologist, and so it's easier for me to recruit patients who have lung involvement. As expected, most of the patients in the registry are women. This is because myositis has female predominance, and so we expect that we would have more women than men. And this fits with what we would see with the overall distribution of sex with patients who have myositis. And then our demographics reflect the population that we serve here in the greater Philadelphia area, which is, I think, a strength of our registry, in that we're able to comment on things that some other registries cannot, just based on the patient populations that we see. And so my earlier work focused a lot on looking at the genes of patients who have myositis, who develop lung disease, particularly ILD, and the genes of patients who have ILD who do not. And what we found is that there were differences amongst those groups, particularly within the group of genes that control our body's immune response, which is not terribly surprising. And one of the things that I wanted to understand was, given all these differences that we see in how patients with myositis ILD behave over time, do your genes influence whether or not you have progression? And what we saw was that a lot of those same genes that predict whether or not you develop ILD to begin with also predicted the people who were more likely to have progression over time. And so one of the things I wanted to do was say, well, perhaps if we not just think about patients just based on their age, their sex, which myositis antibody they have, but also their genes, et cetera, will we be able to actually pick up on different patterns? And so one popular research technique that a lot of researchers are using currently is something called machine learning. And essentially, the benefit of this is that if you could imagine putting together a 1,000-piece puzzle, it would probably take you several days, if not longer, to do it. Whereas if you gave it to a computer with an algorithm, it will be able to take all those pieces and put the puzzle together much more quickly. And so machine learning is pretty similar, whereas you take data from individual patients and you say, let's look at individual genes, their antibodies, their CT pattern when they first came in, their lung function, et cetera. And you put that all in there. And the computer is able to recognize patterns that I couldn't see with my naked eye, or even with very kind of crude statistical methods, and say, are there patterns or groups that we hadn't seen before? And so when we did this with all the data from our Penn myositis registry, what we saw was that there were two groups that shook out. And these weren't just myositis versus myositis with ILD, or men versus women, or anti-synthetase versus MDA5. This was really showing us there were two distinct groups that had clustering of lots of other things. And what this suggests is that potentially what we're seeing is that there are two different mechanisms going on here. And this could be important because this could explain some of the variability that we see in these patients. And it also could suggest that we need to be thinking about the causes of the disease differently, and potentially even the treatment. And so this is really exciting preliminary data. But as I explained, I'm a single person working with about 200 patients. And so when in the world of data, that's not a tremendous amount. And sometimes to recognize these patterns, you need a much larger amount of data. And so the current research project that I'm working on is to actually expand this information by pulling my resources with other researchers in myositis across the country, from the 200 I have here to about 1,000 patients, and repeat this whole process and see with that amount of data if we're able to actually understand more about this variation in patient patterns, and using this machine learning to actually tell us about unrecognized groups that could be important in how we think about what's causing disease and also how we treat it. And so again, the goal of my research currently is to say, how can we better define for patients when we first see them, not in retrospect, their risk factors for progression? Can we discover better ways to actually monitor disease activity? Currently, the best way for us to do that is by following you closely with lung function tests and monitoring your symptoms every 3 to 6 months in the beginning, and then less frequently as things stabilize. But wouldn't it be great to be able to have a blood test or a set of blood tests that would be much more specific and prognosticating for patients versus just telling them when damage has already occurred? Next, this is part of that discovery process and that hypothesis generation I mentioned in my previous slide. And so could we use this information to then go back to our basic scientists and say, are there areas here that we could actually target to then think about developing therapeutics for patients? And then I think the ultimate goal is to really personalize our approach. And so instead of having a one size fits all for every MDA5 or every antisynthetase, is to really say, let's look at all the individual features of this particular patient, regardless of that, and develop a treatment that makes sense for them. And so, again, that is the down the stream goal. This is ultimately what we hope to accomplish. And so, with that, I'll say thanks for listening, and I'm happy to take any questions.
All right, thank you, Dr. Johnson. Appreciate it for a fantastic presentation. So if you have any questions, please put them in the chat. I've got some that were submitted ahead of time, so I could work on that. I would say, just going to say here. So when you talk about so basically, if I'm understanding correctly, pull this up here. Again, what you're putting into your machine learning algorithm or something like that, it's basic currently available clinical data, correct? Meaning it's lab work, right? PFTs, pulmonary function tests, CT results. Is that basically what you're trying to do? I mean, you're basically putting in fairly standard stuff, plus maybe some genetic markers that you're looking at?
That's right. And so part of the expansion is then to expand it to not just include that clinical data and genetic data, but to also include protein markers or biomarkers. And so what are the body's signals that tell the cells what to do? What do they look like in an individual at the time of diagnosis? And so adding that on to the genetic data and doing that in a much larger group of patients.
Yeah, correct. So these 200 patients, those are all basically your patients. So when you're talking about this is Penn's registry, correct?
That's right, yeah. And so I don't personally, they're not all personally my patients, but they're all
correct.
within,
but this is all
they're
on
all
the
within
registry.
the Penn registry. That's right, yes.
Yeah, it's impressive actually. That's a pretty good sized number. So with all those other centers, you're hoping to get that number obviously up to a more significant, but still impressive. Okay. I think so. As you expand this, what are the biggest obstacles you're facing trying to scale this up from 200 patients to 1,000 patients?
Well, I think that we're fortunate in that, one of the things I mentioned in my earlier slide is when I first started taking care of patients when I was training is there seemed to not be a lot of awareness. And I think that's changed significantly. And there's also a lot of people who are actively researching patients with myositis. And so I've been really fortunate in that I've been able to partner with people who have their own registries. And so a lot of the samples that I need for my study are existing. So we do need to do some additional recruitment. About 20% of the participants will still need to be recruited, but a lot of that data is in hand. And so I think the hardest part is just coordinating all of that between the different sites. But the hardest part, again, is collecting the data, and that's already been done.
Yeah. So I think that's important for people to understand. I mean, if the good news is a lot of this data is already out there or reasonable, which is a big, it's collecting it, verifying and make sure it's accurate, and then analyzing it. Yeah, that's impressive. Another quick question would be how, I think as far as what do you think? So we're the main in the ILD world. Okay, in the ILD world, what are the hot topics, if you will, in the research land? So what are the main front burner topics that people are looking at with ILD in research?
Interesting. I mean, I think that if you go to any ILD conference, there's going to be a lot of focus around progressive pulmonary fibrosis. And the reason why is that that's currently where we have our approved therapeutics, and then there's a lot of current therapeutic agents being studied. And so I think there's a lot of interest in that population. Additionally, there's a lot of interest in what they call interstitial lung abnormalities, which are people who have findings that could mean early interstitial lung disease before someone develops symptoms. And some of these people will progress to actually have true ILD and others will not. And so the reason why there's a lot of interest in this group is because a lot of the therapies that we give to treat patients who have ILD, particularly people who have fibrotic ILDs, which does not always apply to our myositis population, but at that point, the drugs do not reverse the damage that's been done. It only slows the progression of the damage. And so the goal is to be able to introduce these therapies at an earlier stage so that before people have a lot of significant lung injury and a lot of decline in their lung function. And so there's a lot of interest in trying to identify and potentially figure out the best way to treat these people who have these early lung abnormalities. And so I think that that's where a lot of interest is globally within ILD. I think that would be the two things that would dominate the conversation. I think that like within patients who have autoimmune ILD, there's a lot of interest obviously around therapeutics, particularly CAR T, but there's also a lot of interest in what I'm doing, which is really trying to what we call endotype these patients and try to understand if we can identify different patient subgroups that may have different biological underpinnings of their disease, and then develop treatments that are specific to those groups. Because I think that what we see is that there is a tremendous amount of heterogeneity, not just in myositis ILD patients, but all ILD patients. But that's certainly very true in patients who have autoimmune disorders, where we see a lot of variation in outcomes and disease progression. And so I think that those are kind of some of the hot topics.
Okay. Following up on that, two quick questions. Number one would be, could you explain for the you do hear people pulmonary fibrosis and interstitial lung disease. People who have interstitial lung disease will know this, which is probably a good chunk of the people on this call. But I think there are a lot of people with myositis who hear of interstitial. So main differences between those two. Could you mention the subtype of somewhat a fibrotic interstitial lung disease?
Yeah, and so as I mentioned in the beginning, when you have interstitial lung disease, you can have either inflammatory inflammation within the interstitial space, fibrosis, or both. And so people who have predominantly fibrosis in that space, by definition, have pulmonary fibrosis. And so any type of ILD can be fibrotic. To make the terminology even more confusing, there's a specific ILD subtype called idiopathic pulmonary fibrosis, which I think people think of synonymously with pulmonary fibrosis. It's not actually true. Idiopathic pulmonary fibrosis across the board is the most common form of ILD that we see in the United States. And if you Google ILD, it's going to be the thing at the top of your Google search. And so this is a very different disorder, though, than patients who have myositis ILD. And so a patient with myositis ILD can have fibrosis, but they do not have idiopathic pulmonary fibrosis. And so the terminology is confusing. And so it's all interstitial lung disease, but again, IPF is a specific condition. And the reason why the distinction is important is because IPF is a progressive disorder that does not have a cure. And currently, the way that we treat it is with medications that slow the progression of fibrosis. But in the majority of patients, even on treatment, they will continue to have progression. That is different than myositis ILD, where some of our patients, as I mentioned before, will actually go into what we call clinical remission, where the disease does not continue to progress. And some of our patients never develop fibrosis.
Right. Have you found in treating your own patients that looking at those two subgroups, if you will, that sort of are emerging from your 100, are you getting a gestalt now when you see patients, which, getting a feeling at least, that there are two, or, I mean, has that helped you treat anybody yet? Just curious.
Treatment, I would say no. So this is a hot, this is a heated debate. So, there's some people who think that regardless of what type of ILD you have, or what is the underlying reason for why you have your ILD, we should be thinking as people as having fibrotic or non-fibrotic ILD. And that if you have a fibrotic ILD, you should be on an antifibrotic. There's definitely indications for patients who have myositis ILD to be on antifibrotic. In my opinion, that should be one of the last resort treatments. And so even a patient who has fibrosis, they may still benefit from being on a medication that treats inflammation. And so in my opinion, I think that's a way too simplistic way of thinking about ILD, particularly in people who have underlying autoimmune disorders. Because I don't know all of the factors yet that are developing our two groups in terms of the underlying biology of why they're separating that way, it hasn't yet informed treatment for me. But I clearly do see some patterns. There are some people who just like respond miraculously to treatment. I mean, you put them on treatment, their lung function improves, stabilizes. In a year, you are able to start slowly reducing treatment. And 2.5 years, they're off all treatment and they're fine. And then I have other people where I'll put them on the same exact combination of therapy, and it doesn't seem to have the same effect. And it's very frustrating because again, on paper, they would seem to be very similar. And so there's clearly something very different about those two patients that currently, clinically, with the information I have, I'm not able to distinguish.
No. And for those out there, I think you're seeing the subtleties, and the subtleties, of a rare disease. And I think that's a very good point, is that as you take care of patients, as you start seeing these weird subtypes that you don't understand, and hopefully 20 years from now, Dr. Johnson and her colleagues will have decoded some of these. But, like if you think about it, this is a rare disease to begin with. And I think you can all appreciate the subtlety and the subtypes of each. They talk about every patient being different. This is a very good example. Couple questions in there. Number one, and for the drug, we're talking to an orthopedic surgeon here. How effective is OFEV in stopping the progression of ILD? I'm assuming that's an antifibrotic.
Yeah.
Is
Yeah.
it okay? Do I get a credit? Do I get a gold star being an orthopedic surgeon with a good guess like that? I don't know.
So OFEV is the generic name for that is nintedanib. And so that is one of the antifibrotics that's currently approved. And so again, the antifibrotics, when you look at them in clinical trials, if you looked at patients who received antifibrotics and then the group that received placebo, so the sugar pill, from the beginning to the end of the study, both groups had a drop in their lung function. But the group that received the study drug had a slower drop in lung function than the patients who received the sugar pill. And so essentially what that means is that this medication slows the progression of fibrosis. It doesn't stop fibrosis. It certainly doesn't reverse fibrosis. And so again, the whole purpose of introducing an antifibrotic is just to slow progression of fibrosis. And so I always warn people that when they go on an antifibrotic that they may continue to still see the numbers go down. Hopefully they go down more slowly, but we're typically not seeing lung function improve. Sometimes people will have their lung function slow to the point that maybe over the next 2 or 3 checks, it remains stable. But if you look at it over a period of years, you will see that the lung function is still slowly going down.
Okay.
But there is a role for using antifibrotics in people who have any form of ILD, including myositis. But that's only in patients who have evidence of progressive fibrosis despite being on traditional therapy. And so I would be a little bit concerned about someone having an antifibrotic introduced alone as their initial therapy.
And no, thank you. Next question. I think it's hard to basically the question, it's a good one, which is preferred course of treatment for those of us with ILD. Very tough question. As I think we've learned. But that being said, taking the important thing there, what are the things new patient presents? Okay, new patient presents to you, Dr. Johnson. What are your sort of things that you look at to help you decide treatment? And I'm not trying to ignore the question. It's a very good question. It's hard to say what's the preferred course for everybody with ILD because every patient's different, as I think you learn. But there's certain things, and what's your approach to a new patient? Let's say, Dr. Johnson, what are the things you look at to decide what to do?
Yeah, and so usually in a new patient, there are a few things I'm looking at. 1, are they symptomatic? 2, is their lung function normal or abnormal? And then 3, what's the extent of their disease on their chest CT? And then the last thing is their antibody type. And so generally speaking, in someone who I think warrants treatment, and that will be someone who's symptomatic with abnormal lung function, or potentially someone who's asymptomatic but has a lot of disease on their chest CT, where I worry that they'll very soon be having symptoms. I'm usually starting with a combination of treatment. And so the thing that determines how many drugs I'm starting up front is really the severity of their lung function, and then whether or not they have an oxygen requirement. And so people who have really severely impacted lung function with an oxygen requirement at the onset of me meeting them, I'm usually thinking about 3 drug minimum. Whereas everyone else, I'm usually starting a combination therapy up front, and that's when the combination is usually a steroid plus a second drug. And so I think that those are the things that factor into my calculus. And so it's usually number of drugs based on all of those factors combined. And sometimes you may not have enough information at the initial visit and you might need a little bit more data. But for me, because I have a little bit of a bias in the people that I see, I'm usually starting treatment on the people that I see. Very rarely I will get a patient who comes in. It does happen sometimes. I'll get a patient who has myositis and they have shortness of breath and they come and see me and they actually don't have ILD, which is always very exciting for me. And I can say, I think you're short of breath because you have asthma, your chest CT is clear and you can try these inhalers. But usually I am starting people on a combination of therapies.
No, makes sense. And it's focusing up on this, answering one of the questions here. In particular, let's say somebody with fibrotic ILD, you know, subtype, you know, what are the therapies? So probably maybe initial frontline and then refractory therapies for fibrotic ILD.
Yeah, so again, a lot of times what we might think of refractory treatments, it may be part of my initial, depending on that severity. Peter, I mentioned when I first see them, but I mean, the things that we usually think of as salvage therapies or therapies once people have failed conventional would be things like rituximab, IVIG, cyclophosphamide. And so those are things that usually, and most people we don't have to reach for initially, and we're only going to reach for them if they continue to have progression on we think is adequate oral therapy. But again, there are some patients where I'm very worried about them from the onset. I might be recommending that they start rituximab from the initial visit.
Yeah, makes sense. Question, no, it's a great question. So put it like this, it's a question is from Barbara. Is there an outreach program to pulmonologists or rheumatologists regarding your research? You know, obviously this can be helpful data for those two. It's a great question, Barbara. It's the world of how do you get, you know, I think this is where your pulmonologist who spoke. So I guess, how is this you know, put it like this, how is your research disseminated amongst other pulmonologists? How do you guys communicate, if you will? Because this is a niche, right? This is a niche market. And I think that being said, if you're in a niche market, you know, medically, you tend to seek out and read stuff from people who, you know, like you. So there's not a formal program, if you will, I would say, but I think Dr. you could explain how is this information disseminated, especially in the rare disease setting?
Yeah, and so I mean, I think the best way for us to disseminate stuff is through publications.
Right.
But then I think, you know, secondly is through meetings. And so there's all sorts of conferences where groups of similar-minded people get together. And so there's quite a few for pulmonary, and then there's crosstalk amongst specialties. And so I will go to meetings for rheumatology. There also are myositis specific conferences, which is a good way for us to know what each other is doing. And that's how you know the people that are in the network. That's part of the reason that I was able to have those other sites is through people that I've met through things like the Global Conference on Myositis, people that I know through TMA. And so I guess a lot of it is just word of mouth. You know, I give talks like this to patients, which I enjoy. I also give talks like this to other pulmonologists. And so I get invited to give talks around the country to different groups of pulmonologists so that they can hear about their research. Not everyone who I speak to is an ILD doctor or a specialist in myositis. And so that's kind of how you get the word across. It's just being vocal, giving talks, going to conferences and publishing papers. And so, yeah, I mean, people do actually find out about us, believe it or not. They know who we are. And I mean, at Penn,
Yeah.
for better or worse, people know that I see patients with myositis. And so I get asked about it all the time.
Yeah.
And actually, one of the things that we did here that was really helpful was we developed a pathway for how to treat our patients who come into the hospital who are acutely sick, who have myositis and ILD. And we go around and we teach the house staff, we teach the fellows. And so there's a lot of kind of like roots up education.
Great. Yeah.
It matters. I mean, I've seen a big difference. I've been doing this now for 10 plus years, maybe longer than that, if I do my math correctly. And in that time period, I've just seen a tremendous amount of increase in awareness and interest. And so the message does get out there, but there's still work to do, but the message does get out there.
No, appreciate it. Last couple questions. So what gives you hope for the future? So put it like this, in your 10 years, you've seen, and trust me, after you've been in practice 30 years, you'll be amazed. You learn how little you know every 5 years. You start realizing that you don't know much. What gives you hope for future treating myositis related ILD?
Well, I think one of the things I've already mentioned, which is just kind of the amount of people who want to study this, and just not in my group, but I have fellows and residents that want to work with me and do projects with relate to my research. And so that's always great to see a younger generation that's showing interest. So I know that there are people in the pipeline when I'm no longer around who will continue to do this work. And I think that there's been a lot of really great discovery. There are a lot of networks. I think we have more and more data amassed. And so throughout the world, I think that even though this is a rare disease, we're gaining more insight where we can pull our information together to try to make discoveries. And so I do feel like the amount of progress that we've been making is significant. And myositis ILD patients are a part of the larger ILD community, which is also growing, and we've had a lot of good insight there. And so I do think that our options are going to continue to grow in terms of treatment options for our patients. So I think there's lots to be hopeful about.
Appreciate it. Last question. So one key takeaway for the patients from your research, if there was one key takeaway for the patients in this audience from your research, what do you think that would be?
Oh boy. One size doesn't fit all.
There you
And
go.
I think we're getting closer to understanding why.
It's great. No, that's what I learned. To be perfectly honest with you, I did not appreciate. I see that in orthopedics in my world and all these this that this your world is infinitely more complicated than fractured bones, knee arthritis. But to your point, all these subtleties matter. No, that's very true. So thank you. So I would say I want to thank you to Dr. Johnson for all the great work you do for the myositis community. I would say 10 years flies by. Thank you to the audience for joining us today. Everybody's favorite topic. Please catch our next webinar. I think it's tomorrow, 6 Eastern, special webinar, chimeric antigen or CAR T therapy. CAR T cell therapy and the biospecific antibodies. Dr. Max Koenig. You can register on myositis.org. And I think I went assuming that, knowing Rachel, she probably put a link in the chat. There you go. So there you go. So thank you, Dr. Johnson. You've been thinking orthopedic surgeon would be asking good questions, but no, you're doing fantastic work. And I think what you're seeing here, people, is when you go to somebody who really is passionate about it, you can just tell, I can, just from sitting here listening to her talk, how she really is passionate about caring for these patients, and will spend the time off hours away from family, et cetera, putting the time in to be better at what she does. So hopefully you got another 20 years left, so you can be, running this show someday. So thank you. I want to thank everybody for your time, and most importantly, thank you, Dr. Johnson.
You're welcome. Bye.